Good morning, good evening, and good afternoon to all our viewers worldwide who are watching the Heartfulness webinar series. And this is your host, Dr. Snehal Deshpande, the CME coordinator and a subject matter expert, leading you into this beautiful webinar, which is going to be hosted on a very special occasion, which very special month, that is October. And in October, we celebrate the Cerebral Palsy Day. Now, what is Cerebral Palsy Day? Cerebral Palsy Day was started by the Cerebral Palsy Alliance in 2012 to celebrate the victories, celebrate the empowerment of the individuals of cerebral palsy. Now, cerebral palsy is a physical disability which affects posture and movement. To know more about it, we have with us our guests, our very special guests, Dr. Chasanal, who is pediatric orthopedic surgeon, and Dr. Pradnya Gadgil. So to introduce Dr. Chasanal first, my very good friends, both of them. She's a pediatric orthopedic surgeon based in Mumbai, consultant at various hospitals in Mumbai. She's a founder trustee of the NGO named Footprints, which creates awareness and supports individuals with cerebral palsy. She was an executive council member of the Bombay Orthopedic Society from 2023 to 2025, and also the Asia Pacific Orthopedic Association, APOA waves from 2023 to 2024. So that's Chasanal. And the next guest we have with us is Dr. Pradnya Gadgil, who is also my very good friend. And she's a senior consultant in pediatric neurology. And she has pioneered a very new facet in management of pediatric epilepsies. She's a clinical lead for complex epilepsy program in SRCC Children's Hospital, managed by NH Narayan Rudalaya in Mumbai. She's also the director of Tuberous Sclerosis Clinic. She's the ex-associate professor in Grant Medical College, from the Grant Medical College and Sir J.J. Group of Hospitals. She's the country lead for India in I think it's a Pediatric Epilepsy Training 1 courses with BPNE. And she's a joint secretary of Samman, that is IEA, in Mumbai. She has been leading the quarterly rural epilepsy camps in Dahanu since 2015 and teaches epilepsy awareness since 2017. A very warm welcome to Mr. Prasad and Dr. Hasya, both of whom have really given in the last minute a yes, and they are uniquely special. So every individual, like we all have a thumbprints, every individual with some cerebral palsy is very unique in their own way. And both these individuals have agreed to share their uniqueness with us. So let us start the webinar with the first question going on. The first person who diagnoses cerebral palsy is a neurophysician, that is Pradnya. So over to you, Pradnya. A little bit about what do you mean by this term cerebral palsy and how do you diagnose it?
Good afternoon. A big thank you to the Heartfulness community for even thinking of broaching a topic like cerebral palsy. So getting on to the technicalities of it, Snehal, cerebral palsy is a brain condition. When we as neurologists say that somebody has cerebral palsy, what we mean is that there is a brain disease, there is a brain problem, which could emanate from multiple reasons, but that causes problems with the typically expected development of the brain. Milestones is a word that gets used very commonly when we are talking about a child's brain development. So if you have cerebral palsy, what you see is that the brain isn't achieving or gaining those milestones. It could be with respect to walking, talking, understanding, and so on and so forth, according to the age expected, according to the age. So it's important to understand that it's a very heterogeneous group of conditions. The cerebral palsy, when we say cerebral palsy, we are describing the look of the disease, that it's a brain problem. It affects the brain's development, and the severity and the degrees and the type can be very variable, and the causes can be very variable. But the most important thing I think that we are saying is that this is not a brain condition that's progressive. It's a brain condition which is the worst of it is in front of you when you diagnose it. And what that also means very indirectly, if you sort of look at it from a other perspective is that the brain disease isn't going to worsen, isn't going to increase. So that basically opens up huge opportunities for brain development. So the worst is in front of you. You work on it, and I'm sure we'll talk about treatments through the course of this webinar. But you work on it, and you expect improvement despite whatever the brain disease is. That's cerebral palsy for you, a very static condition, which gives a lot of opportunities to work upon.
Thank you, Pradnya. And it means a lot to understand that it is a non-progressive condition. And that brings that element of hope. Hope which you're seeing Hasya today, Mr. Prasad here, that this hope, it literally drives the individuals and the families to take care of function, number one, and number two, participation. That's where we as physical therapists really work with the families, participation and function. And one of the most important member of the rehab team is the pediatric orthopedic surgeon. So Dr. Chasanal, coming to you, what are the common signs and symptoms which you would like to describe or which you would like to tell us about cerebral palsy?
So thank you, first of all, for having me here for this webinar. And so after the diagnosis, the signs and symptoms, if we come to it, so usually the brain trauma or something related to the brain which affects the brain happens during the birth, prior to birth or after birth in the perinatal time. But the signs and symptoms may start to be more obvious much later in life, maybe after certain milestones are delayed. So primarily if the milestones are delayed in terms of delayed neck holding, sitting, standing with support, or delay in speech, these could be some of the symptoms which the family might approach the neurologist or the pediatrician with. And the orthopedic part or the orthopedic complaints are usually with the walking, basically the locomotor part, because now when they are always comparing the kid with the other child, that the kid is not standing at 1 year or maybe even after that time or standing on toes, I think that's the first sign where they need to be investigated further and made a diagnosis that it's a CP. Because there are a lot of other conditions which would look like CP. And that's why meeting a neurologist is a must before we put a diagnosis or label anyone as CP. That is roughly around age 1.5 to 2 years. So I think that's when the diagnosis and the signs and symptoms are largely evident.
Thank you. Thank you for that wonderful answer. And I'm sure that as a physical therapist, when I look at early detection and early intervention, right from the NICU, so I call myself more than a physiotherapist, a developmental and a neonatal therapist, because NICU is the place, the hub, as we say. We have all hubs, like we have Hyderabad is a software hub, or Bangalore is a hub. So like that, NICU is a hub of very powerful potential kids there. And if we start with them from the NICU, I think we can give them the best for their world. And that's where the logistics, as we would like to say, that there are about 17 million people across the world living with cerebral palsy. And there are about 350 more million caregivers who are associated with people who know individuals with cerebral palsy. And this is a complex disability. One in 4 children with cerebral palsy have problems with communication, 1 in 4 with locomotion, and 1 in 4 again with epilepsy. So coming to this topic of epilepsy, Pradnya, what do you feel is the management further, and what would you want to say something about epilepsy and cerebral palsy?
Yep. Epilepsy isn't a different disease that kids with cerebral palsy have. It's part and parcel of the symptom complex. So you have a brain injury, you have a brain disease. One symptom of that is the cerebral palsy aspect of it, which is problems with the development, with walking, talking, and so on. And the second symptom of the same brain injury is a tendency to experience seizures, which is epilepsy. Thankfully, epilepsy and cerebral palsy, though it's common, it's not compulsory. It's not necessary that every child with cerebral palsy will have epilepsy. So that's a very important take home. But of course, we as professionals, we are looking for it all the time, because the likelihood of epilepsy happening in kids with cerebral palsy is much higher than people who don't have CP. Uh, uh, there is a small percentage of patients present with epilepsy in the first year of life, and sometimes that's a time when the cerebral palsy also gets diagnosed, because the seizures come forth the first. And those are the seizures which we are quite worried about, the ones which start in the first year of life. So sort of circling back to what you said, Snehal, around that early intervention in NICU. So when we have kids who are getting discharged from NICU, we like to, in ideal world, we would like that family to be sensitized that this is a kid who's at risk of developing cerebral palsy, a certain type of epilepsy. So sensitize parents, empower them to look out for the signs of both. In fact, don't wait for cerebral palsy symptoms to occur. Start the early intervention from NICU itself, because the brain's most amenable to change and to improvement the younger it is. And of course, sensitize them to look for these seizures, which are very subtle. They are almost like chamakna dachakna kind of a thing in the first year of life. Because the general expectation around seizures is a very dramatic event. But when seizures in epilepsy happens in the first year of life, they are just startles or jerks, or almost chamakna dachakna in Hindi, as they call it. Those are the ones where we want to see these kids very early on and start treatment. Having said that, seizures can develop in people with cerebral palsy at any age. If they don't develop in the first year of life, then the ones which come on later are typically slightly easier to manage as the ones which start early on. How do we manage epilepsy? We diagnose it by a mixture, just like cerebral palsy actually. We diagnose it by a mixture of the story that the parents tell us, our neurological examination of the child, sometimes a couple of tests, and then the treatment of epilepsy is largely with medications. So we have quite a number of anti-seizure medications which help to control the epilepsy quite well, honestly. Previously, it was thought that medications which control seizures make the child or that person very dull. Sort of they look like zombies, so, to quote unquote. But I think the advances in medical research have made these medicines very, very easily tolerable. So there could be some of us on anti-seizure medications and you couldn't tell. So managing epilepsy has definitely become way more easier, especially the patient experience of it has become much more easier with the advances in research. And the ones who don't come under control with anti-seizure medications, we have quite a few types of surgeries, ketogenic diet, sometimes precision medicine to help treat epilepsy. So the epilepsy problem in CP is actually, I think we are able to do a very fair job of managing it very well. By very well, I mean in such a way that despite having the epilepsy shouldn't affect the rest of the quality of life of that child or that adult. It's only about 10% of patients who have a very difficult epilepsy where we find ourselves a little bit underserving that patient.
Thank you so much. And coming back to you, Dr. Chasanal, we all know that, of course, Pradnya deals with the organ called brain. And brain is something which controls everything, right from our thinking to functioning to talking, everything is controlled by the brain. But as an orthopedic surgeon, you deal primarily with the muscles and joints. And of course, the individual, all of us are definitely dealing with the individual at different levels, but you're looking at the muscles and joints. So coming to you, what would be the signs and as we say from 0 to 1.5 are the early signs, and then as the child grows, the complexity of what we see increases. So could you talk about this a little bit, the journey of bones and joints and muscles from the childhood, from babyhood to childhood?
Yeah, so So yeah, true. The CP needs a lot of comprehensive attention. Like few of us are here today, but there are more other people who need to be part of this treatment of an individual. Like you said that we look at CP as an individual, and we don't treat them individually as well. So there's always a comprehensive treatment approach. And I always like this term, which the sentence, and I always want to quote it, that it takes a village to grow a child. So same way it takes a team to address problems of a CP child. And in other terms, CP as an ortho, we describe it as a neuromuscular problem. So what Dr. Pradnya mentioned about the neurological impact and that it is a non-progressive problem. But the second part, that is the muscular, is a progressive problem. Progressive in the sense because when the baby is born, it's a small baby. And then it has certain growth spurts and it has to grow skeletally and muscular. And in all terms, the child has to gain a height and growth spurts and grow accordingly. So primarily when the brain is affected due to any perinatal insult, the motor part is the major which is affected. Motor in the sense the walking part or the muscle related part, the muscle coordination, the muscle tone, all of these. So largely the tone is spastic. That is usually the CP children tend to be a little bit tight or they hold themselves like that. In medical term, we call it spasticity. In little layman word, we would say tightness. And this spasticity initially starts in certain group of muscles, which can be seen as decreased movements of those joints, children walking on toes, children walking with knees bent, or holding on the upper extremities in certain positions, not being able to grasp objects or do certain activities. And classically, what the parents expect them to be right-handed, the dexterity gets little late and they are unable to understand which hand they are supposed to use. All these smaller things could be visible in terms of skeletal, that is hand and lower limbs. As the spasticity increases, now the muscle is initially spastic and eventually as the bone grows and the muscle tends to remain tight, then the muscle goes into a contracture. So spasticity is like a rubber band. We can just pull it. So some stage, the muscle is like a rubber band. So you go to Dr. Snehal and she'll do nice therapy program for you and everything will look nice and good. But with the second, maybe a first growth spurt or sudden increase in the height, this spasticity or this feeling of getting a movement might reduce, wherein the muscle has gone in contracture. And after the muscle goes in contracture, now it adds tension on the bones. So initially the muscles on the thigh, if they start going in contracture, they cause the thigh bone to turn inward. And these kids will like to sit in a W position, which is not a very good thing because subsequently now the bone has changed its shape and it leads to a long-term complication of dislocations of the hip. And once in a very long run, once these hips dislocate and their angles change, the pelvis obliquity changes, and then these kids might also get a problem in the spine, that is the scoliosis, that is a curve in the spine. So this is what largely happens, like the way how the muscle affects the bones in the long run, and eventually the posture of the kid or the posture of an adolescent is with a pelvis being slightly upward or the spine being curved or certain fixed deformities at the knees, the feet having certain deformities, is all a small little spasticity causing this. Now there are other problems where there is not a spasticity, there is a lower tone, which is a little less percentage, that is around 30%, where there will be not a tightness, but there'll be a weakness. And here the skeletal problems will be slightly different. Here the child may not be able to sit or stand at all because of low tone. And Another third pattern would be where they have uncontrolled movements, that is a dystonia or an athetoid or a mixed type of CP. So that will have to be again dealt differently, and they'll have different set of skeletal problems. So that's how usually the bone and joints react with CP.
The earliest which I have seen an orthopedic surgeon who can operate on a child or a baby is when the hips are affected. So I'm sure you would like to comment on that hips are very important in children with cerebral palsy. Maybe we can come to this after the question which Pradnya can do for us. Is Pradnya, if a family approaches you for okay, my child has delayed milestones and my child has increasing stiffness and my child has some, if he tries to hold a glass, then his or her hand becomes tight. What is a treatment prescription you would advise for family with cerebral palsy? Would it be the same for everyone or would it be different for different people?
So that's a great question. I think what this brings to fore is what Chasanal was saying, is that the treatment of cerebral palsy is multidisciplinary. So all the problems that what you've said is, this is a child who's delayed in his or her milestones. This is a child who has problems in walking, and this is a child who's having problems with the fine motor movement. Okay. So I think as a neurologist, we probably somewhere serve as an anchor, and I think it's important to get the point of this requirement of a multidisciplinary care across to the family. So I think that's the biggest thing that we do, apart from the actual prescription of medication, saying that you will need a village, like to quote unquote Chasten here. You will need you need doctors, you need therapists, you need medications, you need sometimes you need what we call orthosis, which are very loosely gets called special shoes kind of a thing. So you need orthotists who will make it, and of course the parents have to be part of the team. So that's the big team that looks after these kids. The specifics would differ. If it's spasticity, then the medicines would be different from, say, a chorioathetoid or a dystonia kind of a CP. If they have problems with cognition, then the way you would train them would change. You would also want the speech and swallow to be looked at, the vision and hearing to be looked at. You might need physiotherapists, occupational therapists, speech and language therapists, remedial educators. So what kind of therapists are needed would also change, and that's very tailored according to that child's needs. The needs also change with time, which is why that 3 monthly, 6 monthly surveillance, almost like a project at work or a job. You say that this is where we are at baseline with respect to different abilities that are expected of the child. You almost make a problem list. Then you plan treatments with respect to medication, therapy, which therapists are going to be involved, which doctors are going to be involved, and you reevaluate in 3 to 6 months. And this keeps going on with an aim to just being able to help the child to further his developmental milestones, despite the fact that he or she has CP. So it's a very ongoing treatment process. So specifically, there are medicines, there are tablets or syrups, which might help to control that abnormal tone. There are medicines which help excessive drooling. There are medicines which help excessive abnormal movement. There are medicines which help sleep, because that's often a problem that we see. Medicines for seizures or epilepsy, if that's needed. Then we talk to our orthopedic colleagues. We pick up the phone and say, oh God, Chasanal, this is a kid who looks like the spasticity has gone up. Would you want to do something? And then Chasanal might come up with saying, oh, I might want to give an injection of a botulinum toxin, or I might want to do surgery. Of course, we then speak to the therapist and they say, yes, we need to do passive exercises. And I'm sure, Snehal, you are the person to elaborate on this. But a mixture of exercises, plus minus orthotics, and this is ongoing. So that's a treatment journey almost that a family should expect if and when we diagnose a child with CP.
Thank you, Dr. Pradnya. And coming back to what we were discussing, Dr. Chasanal, the hips and cerebral palsy. For us as physical therapists, everything is the base. What passes through the lips comes through the hips. So even the speech and the communication and the feeding completely is dependent on the hip stability. And hips are definitely affected and become complicated in children who are affected, as we say, GMFCS. So gross motor classification function system is something what we use as professionals for the benefit of everyone. And children who go higher, there are level 5 and level 4 children in whom the hips are affected, and that's where Chasanal comes into action very early. So over to you, Chasanal, for your comments on this.
Yeah, so certainly, like you said, hips is a very important part for walking and sitting balance, and also for maintaining the spine alignment. So what we call this term as hip surveillance, like we have to keep a watch on the hip. And the watch starts very early in life, that is age 2. So, so the GMFCS, that means gross motor function classification system, it's 5 types. 1, 2, 3 are the ones who are walking, and 4 and 5 are the ones which are not walking. So the more hip surveillance is stringent in children who are not walking, because here their hip starts getting affected much earlier in life. And the GMFCS 4 and 5, which are wheelchair bound or totally non-walkers or non-ambulatory children, they need annual x-rays which start from age 2 years. And at certain point, if we see that the hips are migrating out from the acetabulum, that is the joint, then they might at times need a 6-monthly x-ray as well. While the walkers, that is the GMFCS 1 and 2, who are community walkers, who go to school by themselves, who go to the market, go to the mall, they are like community ambulators. Yeah, so these kids, they would need a much less surveillance. So initially from 2 to 6 years, they might need annual x-rays, and subsequently x-rays every 2 years or 3 years. So it's very important to keep a watch on these hips so that we catch them early, treat them with certain braces and physiotherapy. If not, then smaller or less major surgeries, which don't involve a lot of bony procedures, and which all this is aimed to avoid a dislocation in the hip. So that's how the hip surveillance program goes. And currently it's of very much importance. And all over the world, this hip surveillance program is followed in a uniform manner. And this is how it is done.
Thank you. Thank you, Dr. Chasanal. And coming back to Dr. Pradnya, I think when we talk of hips and spine, it becomes just a part of the musculoskeletal system. But as we were speaking, that it is the individuals and the families which are affected in cerebral palsy. So how does cerebral palsy affect the daily life of the people and the individuals, the family and the individuals?
So, like I said earlier, cerebral palsy is a very heterogeneous condition. So, it's a spectrum. There are children who have cerebral palsy and can't walk, can't communicate, forget talking. They can't even use actions or gestures to communicate their basic needs, are fully dependent. That's one end of the spectrum. And then you have the other end, where they are able to function completely independently as they grow up, and be very independent members of the society. So what daily life would look like for the child and the family would really depend on how severe, or what are what aspects are affected the most. However, broadly speaking, I like to use school as an analogy, like how we have a child and then we start preschool and then primary, secondary, and then college and so on. It's like you go through stages and you are looking at improvement in the child. Similarly, a child with cerebral palsy, no matter how what is the severity of the problem, you are always trying to take them through various stages, and it's personalized, tailored for each child. So you start off with getting them to roll over and try to sit, then you try to get them to ambulate. Ambulation may not necessarily mean walking. It could be assisted ambulation in those who have a more severe type of the disease. The ones initially try and teach them communication using actions. If they start speaking with the help of speech therapist, occupational, great. If they don't, try and use assisted methods of communication so that they can communicate, with the aim being whatever is the ability of that child, you want to try and help that child to reach that. And the ideal ability would be that they don't need assisted living, that they are independent, at least for the day-to-day needs. And then if they can do more, then that much more. So for the family, it's like just like for any other family, it's coordinating with the school, the homework, the drawing class, and the maths tuition and football and so on and so forth. For a child with CP, the family has to coordinate in a very similar fashion, but probably with different individuals. It could be the orthopedic surgeon, the physiotherapist, the remedial educator, the neurologist. Like with all other kids, you're looking at nutrition with equal fervor, whether a child has CP or not, and you are continuously appraising and looking at the progress. So sorry, it's a very heterogeneous answer, but that's what CP is for you.
I would like to just share this slide, when we are talking of it. I just had a chat with one of for a hospitals on one of our patients, and this is a beautiful framework which has been introduced by the Can Child. That's the website which has been described, and this is how we all professionals look at and individuals look at cerebral palsy in this framework, that for every child, it is important that they have fun. So we may think of therapy, we may think of hip surgeries. So every individual wants to have fun. Today being a Sunday, I'm sure many people would want to go for a movie, want to go out with friends. So it is fun, and friends and family becomes extremely important for an individual with cerebral palsy, as for us as well. And that's the reason we as therapists look at functioning, that I might do things differently, but I can do them. And fitness is, everyone needs fitness, whether it is mental fitness, whether it is physical fitness. So that's where the body structure and function comes into picture. So having friends, having fun with friends, a great support of the family, and participating in every part of life is something what we really need to look at. Is a broad framework which we all, and definitely as Dr. Pradnya mentioned, needs of every person at every age would be completely different. But at the end of the day, when we say that the child wants to stand, he wants to stand for what? So he would want to stand to remove his shirt, or maybe keep the books up, and we as therapists come into, okay, this is the patient goal for the child. So thank you, Dr. Pradnya, and I was really good to share that slide. It was
That's
just
a lovely,
there.
that's a lovely slide. It's a very nice, like a guide for all of us to sort of think of the 5 Fs is how I'm going to remember it. The 5 Fs for looking after children and families with CP.
Thank you. And coming to you, Dr. Chasanal, do you think every child who comes to you needs a surgery? I mean, I know of certain organizations, camps which are held for people, and individuals flock to these camps and they get their limbs dissected. And I feel like, what is this? Is it butchering the child? So coming from you, what do you feel? Does every child need surgery? And what are the effects that these surgeries have on our children?
So, yes, we really feel sorry for those mass camp approach to children, where everyone is addressed with a single surgery. So that is a very not a very good way of addressing surgically an individual with CP, and certainly not everyone needs surgery. So the newer terminology what we use is called dosage of surgery, or an a la carte approach. Like every child will need a certain dose of surgery, and it can be a combination of an injection of botulinum toxin, maybe phenol, or and some other chemodenervation agents as well. And then there would be certain surgeries where the contracture or muscle tendon lengthenings are done to achieve good movements at the joint. And some surgeries which are inevitable, like if the hip has dislocated, it has to go back in. So even if the child doesn't walk, so many a times we come across the non-ambulatory children with hip dislocations, and their parents always feel that if this hip goes back in with the surgery, the child might walk. So explaining the family that the goal of the surgery here is not to make the kid walk, but first it is to get the joint in place. Because if this femoral head, which is supposed to remain in the joint with a fluid around it, stays out for a longer time, then the cartilage starts getting damaged. And it leads to exposure of the nerve endings on the joint or the bone, which is very painful. And these children, especially the non-ambulatory ones, it's a big trigger for epilepsy, the exposed joint cartilage out of the joint. So they start getting convulsions, they lose on their sleep, they stop eating. And many of these kids, they succumb to this pain. So there have been a lot of scores, especially the CP child scoring system, which talks about problems in a non-walking child, where it has been shown that how even this small little pain can lead to all these problems at times. So not necessarily all of them will need surgery, but as and how, whenever needed, depending on their functional requirements and what all their activities of daily living are hindered, only those can be addressed with a dosage of surgery at different ages, maybe at certain growth spurts or so.
Thank you, Dr. Chasanal. That was very comprehensive, and I really, there are many times when I get these individuals who have been operated very early,
Yeah.
very early, and it's like the elastic. I always
Yeah.
tell parents that muscle is like an moment you cut the muscle, you're weakening the muscle.
Yeah, so it's always better to wait, because it is if in doubt that if this muscle needs a surgery or does not need a surgery, then it's always nice to wait and do it later, because doing it unindicated will cause over lengthening, weakening, and these problems can't be reversed. So many of the problems are impossible to reverse back, and that's why always waiting is the better option rather than hurrying in a surgery. And they should, I think, always have a trial of certain therapy, different modalities, different set of therapies, and even that changes. So suppose if somebody is just into land therapy, they can probably take aqua therapy and things might certainly change. That's what we look at. And even other therapy modalities sometimes help them, because at times it becomes a monotonous therapy program for kids as well. And adding certain different modalities helps them.
Yeah, I think I'm going to butt in here, but making therapy fun is probably the most challenging aspect of therapy. So yeah, I think aqua is something that most kids would love. Don't think they're in therapy. So I think the challenge here is that you're dealing with kids, and then translating all these medical experiences into fun experiences for the child is a big challenge. So a big shout out to therapists who do this on a day-to-day basis.
Yeah, we have fun in our sessions, and that's why I love my profession, and I'm here. I seriously love being with babies. There are days I don't work, like today I'm here. I feel the loss. It's my loss not to be with them. So to you, Dr. Pradnya, what are the treatment options from your side which are available for these? As Dr. Chasanal mentioned, aqua therapy. So what are the other, options other than just therapy? What are the options available?
The biggest other option, I think, which doesn't get talked about in our country, especially, is inclusion. I think Because yes, so there are medications. I mean, just to sort of go over a list, if that's what you expect me, Snehal, there are medicines, and the medicines are very symptom driven. The medicines don't cure your cerebral palsy. The medicines help you with with certain symptoms that cerebral palsy pops up. It could be stiffness, it could be sleep, it could be excessive salivation, it could be seizures, so on and so forth. So medicines are like if you get malaria, what paracetamol does to your fever and malaria. It doesn't treat the malaria, it just helps you with the fever and malaria. That's what medicines do in the context of cerebral palsy. Of course, nutritional supplements are important because the musculoskeletal system gets so affected. Sometimes you have feeding difficulties, hence the nutrition might get affected. So a big close eye, a regular eye on nutrition with respect to bone health and general nutrition is important. Therapies are physiotherapy, but we like to think of it as neurodevelopmental therapies. So therapies which are designed to help the brain to develop skills and capabilities despite it being injured or damaged or diseased. So it's a big task. It's almost like asking somebody to drive a car blindfolded and with one hand tied behind your back. It's important to remember this because very often the society, the families sort of come to us saying, "Abhi bhi chalta nahi hai, abhi bhi bolta nahi hai." But if they do even little, that's such an incredible achievement because it's done in the context of a brain disease. And that sort of brings me to the point of inclusion. There are kids which all of you work on so beautifully and get them to being ambulant, get them to start talking. But there might be, like I like to think of it, 19-20 ka farak, between them and what's expected from a neurotypically developing child. So the inclusion becomes so important, especially when it comes to education. These are kids who might need a little bit of help with writing. They need a writer. They might need extra time. They might need to drop off a few subjects. Honestly, kids who don't have cerebral palsy also need these kinds of help. So it's not very unique to cerebral palsy. But if we are able to provide that inclusion, so the school has to be inclusive, you have to be able to provide the shadow teacher, remedial education, and so on. And then inclusion doesn't stop at school level, it goes on to higher education and then goes on to employment. So that all the successes that these kids and now adults have had overcoming the core symptoms of cerebral palsy, they can actually put them to good use and become independent members of the society. I think I am not the right person to talk about it. You have two stellar living examples here of having cracked this. It's like almost climbing Mount Everest in my mind, if you're able to do it. But I think that's an equally important aspect, which in India doesn't get implemented as well as it should be. I think we are doing a great job with respect to the medications, the therapies. So wherever the medical community has to chip in, we are, I feel very proud that we offer everything that the rest of the world is able to. But when it's the facilities that these kids require, which are outside of a hospital or a medical setting, that is where our country still needs to do a little bit more to make them inclusive.
So now, as you rightly brought them in, I'm going to now call upon our very, very special guests for this program, Dr. Hasya, who has, in spite of all her, she has made the word impossible into I am possible. So over to you, Dr. Hasya, and thanks for joining us for this show. And what would you like to express? I leave it to you rather than asking you a particular question. I don't want to limit you. I would just say speak something about yourself, and it's so appreciable to come up to this.
Firstly, thank you so much for making me part of this. I'm really glad, and I'm also very happy most of my points have been covered in very well mannered. So this shows there is a more patient doctor interaction going on very well, because sometimes that uncertainty and the gap between the patient and doctor kind of bring a lot of roadblocks to the journey. So I would like to thank the team, and I hope more doctors like you and more awareness reach everyone, and let the disability be cured in the soonest possible way. Like the sooner it gets treated, the better it is. because you left it to me. I don't know where to start with, but I have seen personally certain challenges mentally, physically, and I would like to address it. Translating something which is very complex to daily basis is very, very important. That is the step that is needed. And rightly said, opportunities need to be, you need to act on it. So for someone who is having a disability, it is very difficult for them to take that opportunity because they're always in this fear of failing or not having the power. They'll have this feeling, what if I fail, or I'm not good enough like anyone else. So maybe even just because I wrote my NEET UG, I had a possibility of getting access to MBBS. So ACT itself is a big win to people with disability. And I would encourage every parent and everyone around them to please have patience. This is a long, long process. I wish I could be a magician and tell this is how you fix it, but that's not how it works. Being a doctor, I understood how layered it is. Now, cerebral palsy in itself is an umbrella term. They say it's not a single diagnosis, it's very much layered. So, it is a long process, people, and have a lot of patience, keep working on it is one thing I would like to tell. And also, the biggest challenge I have faced is with the adaptation. Most of the CP requires multiple surgeries generally. So what happens is after your first surgery, you're neither completely walking properly nor you're able to walk like your previous self. Now this is the biggest challenge I have faced. For the longest time, walk properly used to trigger me like how and how. This is like a telling someone to do something and not telling them how. That would be biggest trigger to patient from my side. So I think I would feel take it as a bottom up challenge. Take it slowly, day by day. The change is important. Most of the time, what happens is the surgeons, all the doctors will do their job. The challenge comes with rehabilitation. That is where your game begins. Please do follow up with your doctors. Please get back if you have any doubt. Please stay in touch with them. Please take their inputs. That is how you stay connected with them. And also, I feel there are certain lifestyle changes that one should bring in to have a better life. For suppose for someone who is having a moderate to low disability, I'm talking about this spectrum of people who are able to do it but not efficiently. So what happens is, for suppose giving them a gentle reminders and a command could help them. For example, when I went to follow up to meet Dr. Chasanal, the first thing she told me, "Has your stand straight. Put your legs stand." Like, inputs like this, because you're not aware of it, unknowingly, the old part of you will kind of, get affected, and there is a high chance you're going to your old patterns. So it is a practice in itself. So I think parents and the friends around them to have that gentle reminders, put your chin up, keep yourself down. This kind of inputs, I don't want to pester them with the commands, but gentle reminders could help them to do better. And also, I believe uh, building a reward system. Like, instead of telling them there's something wrong with you, you need to do the physiotherapy and all. Like rightly said, the fun part is needed. Maybe tell them, if you do this physiotherapy, I will take you out for a movie. I'll buy you this, or because you have to create that positive mindset is what I believe in. I still remember I just wrote NEET UG because my father told me he will teach me how to drive. Now the most affected part of my limb is left. So I have made my mind, okay, now if there is a problem with the clutch I'm using in the car, I will learn automatic. But I want to learn the car. So that is why I gave the exam. So I think telling people and in a positive way, helping them to do, okay, this might be very subjective, and there are people with extremes who are not able to do it, but I'm talking about the major part of the people who are in their journey. So things like this, parents building a community and telling them you're not alone is much important. You will have people with more severity, with less severity. So rightly said that that inclusion is very much needed. Having said that, I have also seen people like people being away from normal set of people because they feel there's something wrong or something low between them. That needs participation. Maybe you want to sing, give it a try. Maybe you want to dance, give it a try. You are doing it, and you're doing it is a win. So I want people, I came this far only by participating in it. My mom always pushed me out of my comfort zone and just wanted me to do things. You might fail. People may stare at you, people may bully at you, but trust me, there are a lot more people who are able to communicate and who are able to help you. And I still remember the teachers, the friends, the circle you have, they would definitely help you. Ask for help. There is nothing wrong in asking for help. I still remember there was this incident. I was very hyper independent. There was a phase where I was very, I don't know why am I all this independent and all. So now I am in this hyper independent mode where I used to not ask anyone for anything. That is not healthy. You can ask for help. Maybe you're going for a walk. Your friends are able to walk for 10 kilometers and you're able to walk only for 1 kilometer. That's okay. You tell them, I will sit here, you come back, you join me, or you tell them, let's sit for 15 minutes and we'll start again. So instead of stopping yourself from doing something, start it and do it slow is what I would like to help. Everything starts from single day, that the day you have to show up for yourself every single day. And that is the toughest part of CP. I have been dealing with this since 24 years and I underwent maybe around 5 surgeries, and I'm still in the process, not losing hope. I'm still updating Dr. Chasanal with my videos and just hoping for her inputs, and I'm just wanting to get better. I think this is very important for everyone. And parents, please, please don't isolate them. I know parents will have this mindset like, when everything gets right, then I will take them out. When that is not going to happen. Please do so. Let them socialize. Let them let the steering be there. You will be bulletproof to it. Trust me. Haters are gonna hate, and you are going to move forward more, maybe better than them. So please include them. Give that little reminders to them. Be gentle with them. Have patience with them. Maybe if there are people who are using aids like splints and all, make them very nice. Make them. I used to remember I used to stick the superheroes on my splint, and I used to go and tell them this is my accessory. Just like Captain America has his shield, and I have this. So make life interesting on everyday basis, and it is a slow process. Maybe you will not able to see the finish line, but you will see the next step that is in front of you, is what I feel. So it is a long process, and I was not known that I didn't know it was a long process. So every time after a surgery, I was not getting the betterment that I wanted. Always used to, that could hit on my health, self-confidence. So what I would like to say is bringing awareness in itself, telling them it is a long process and it takes multiple surgeries, or, this time period is itself very much important. So yeah, thank you for making me this part, and I hope I made some value to it.
Great. So
Very nice.
our next individual, Mr. Prasad, thank you so much for joining us, and over to you. I would love to hear from you. Prasad has traveled a long journey and he makes himself there. He's working for JP Morgan. Over to you, Prasad, for your whatever you want to say, your challenges, how you have dealt with them, who is the person who has supported you, and what brings you to this level.
Yes, doctor. Thank you for inviting me to seminar. So I am Prasad Raut from Mumbai. So I completed Bachelor of Degree in Information Technology in Atharva College of Engineering, Malad, Mumbai. After that, I got opportunity in working in JP Morgan and Chase. So I I was going to Bangalore for the JP Morgan training program. It is a differently able taken program. So they taught me to build the software in 3 months. After that, they taken the test on HackerRank. So I clear my test and I got an opportunity in JP Morgan and Chase as a software developer. So here I am from primary education to bachelor education, I am facing more and more problems in my daily routine. So, yeah, doctor, can I speak in Hindi so it is more comfortable?
Absolutely, Prasad. Whatever you're
Yeah,
comfortable.
okay. So डेली रूटीन में मतलब 60% एक्टिविटीज में डिपेंडेंट था मम्मी और पापा पे. सो व्हेन आई केम इन मुंबई, सो सो मैंने बहुत सारी चीजें सीखी, जैसे लो, लो, डेली ट्रैवलिंग ऑन इन लोकल ट्रेन. सो 15 days मुझे हेक्टिक लगा. तो उसके बाद आई कैन ट्रैवल एज अ नॉर्मल पीपल. सो सो मुझे वॉक चलने में बहुत तकलीफ होती थी. तो आई अंडरवेंट फ्रॉम सर्जरी in after 10. So I take a 1 year gap and then I pursuing my diploma in Vasai. So before living in Mumbai, I live in Vasai. So डिप्लोमा कंप्लीट करने के बाद मालाड में बी के लिए एडमिशन मिला. तो मैं वसई में ही रहता, तो वसई टू मालाड डेली अप डाउन करता था. सो मुझे बहुत प्रॉब्लम फेस करने पड़ते थे. बट जो लोग रहते वो बहुत हेल्पफुल थे और मेरे फ्रेंड्स भी बहुत हेल्पफुल थे. तो आई एम टैकल दैट प्रॉब्लम इजीली. एंड in exam, there is a 3 hours and exam. So when I am writing an exam, my full body was tight. So I can't get 100% in the exam. So मैंने KG to PG तक जितने भी एग्जाम के पेपर थे वो खुद से लेके, टीचर ने बोला था कि राइटर लेके एग्जाम दे दो. लेकिन माय डैड से कि तू कर सकता है, तू खुद से पेपर ले, भले तू फेल हो जाएगा तो भी चलेगा, लेकिन तेरे को खुद से ही पेपर लिखना है. ऐसे मोटिवेट किया मुझे. और बाद में मैं डॉक्टर स्नेहल के पास गया बिफोर 1 year. सो आई टेक ट्रीटमेंट. सो डे 1 से मुझे इफेक्ट दिखने लगा. सो जो मेरा 60% डिपेंडेंट था वो ओनली 5% अभी है. सो 1 year में बहुत प्रोग्रेस हुआ मेरा. सो आई कांट टाई माय बटन ऑन टी शर्ट. सो वो भी मैं इजीली कर पाता हूँ. और वॉकिंग में 50 to 60% इम्प्रूवमेंट हुआ है. तो बहुत इम्प्रूवमेंट है. और एक कॉन्फिडेंस आया है कि मैं ये कर सकता हूँ. ऑन द थेरेपिस्ट, जो मैंने 30 years में नहीं किया था वो एक्टिविटी भी मैं इजीली कर सकता हूँ. लाइक balance on balance board, etc. And my right hand से मुझे only 5% काम होता था, लेकिन अभी मैं ट्रीटमेंट ले रहा हूँ तो मोर देन 50% राइट हैंड इज वर्किंग। एंड जो भी बॉडी का मूवमेंट होता है वो ऑटोमेटिक होता है। पहले मुझे बोलते थे कि आप जब वॉक करते हो तो आपका हाथ पीछे जाता है, पीछे नहीं जाना चाहिए, वैसे बोलते थे। लेकिन आफ्टर 1 मिनट वो ऑटोमेटिक पीछे जाता था। लेकिन अभी बॉडी ही एडजस्ट कर लेती है। और जैसे नॉर्मल पीपल चलते हैं उनको याद नहीं रखना पड़ता है, अरे हाथ पीछे नहीं जाना चाहिए, वैसे ही वो पीछे नहीं जाता है, ऑटोमेटिक सब हो रहा है। इट इज अ ऑटो पायलट मोड। तो मतलब बहुत इम्प्रूवमेंट हुआ था। एक्चुअली मैंने पूरे लाइफ में कभी सोचा नहीं था कि इतना इम्प्रूवमेंट होगा।
Thank you. Thank you.
Yeah.
It means a lot. I think words from Hasya. You all are the leaders for the community, and your stories of courage will definitely keep inspiring a lot of families to walk the way. क्योंकि ये राह चलना, walking the way, for a family is very, very difficult. And
Yes.
the thought that the goals are very attainable. So quite a few of our patients have good careers. One of my kids is now into M-Pharm. One of them has become a speech therapist. She was encouraged to become a physiotherapist because of me, but now she's taken up speech therapy. One of them works for Accenture. So there are a lot of these success stories which we have known. And kids are very inspiring. So for us, for me especially, what who inspires me to go back to my work are the kids. When you see them doing so well, you feel like being with them and not at home. And that's what keeps me pushing. I push off and I say, I want to go home, go to the clinic, which is my second home, and I want to be there with all the kids. So I think that must be the same thing with all of you, Dr. Chasanal and Dr. Pradnya. And as we come to the last lap of this seminar, webinar, one question to both of you. What are your future thoughts about this condition for India? What do you want to do for India? And if you want to do something different, we are here to help you out.
Can I go first, Chasanal?
Yes.
I hope to be out of business. I hope that we are actually, at least to a large extent, prevent brain injury so that we have lesser number of kids with CP. Not all causes of CP are preventable, but quite a few of them are. And that's it's not a pipe dream, it's truly attainable. The developed countries have led the way. There are enough medical processes, techniques, and so on to ensure that a lot of CP doesn't exist. So my dream will be that I have less work, I'm out of business, there isn't this element of acquired brain injury goes down. We unfortunately have large numbers in India, given the challenges in primary healthcare, and that needs a serious, lot of serious input from multiple agencies, starting from the government to the grassroots health worker. But that's my wish list, that we reduce the number of acquired brain injuries and hence actually reduce the number of cerebral palsy patients in India.
Yeah, I totally agree with what Dr. Pradnya is saying. So currently the neonatologists, they put a lot of efforts. A lot of things have changed in terms of the degree of the hypoxia which the child faces at birth. And even those kids, if taken care nicely during the immediate birth period, after birth, so they don't result in CP. And I think what you mentioned earlier, that these kids need to be followed up. So with me, I have joined certain NICUs, and over a period, past 10, 15 years, we have formed high risk OPDs, where all the new NICU graduates have to follow till 1 year with an ophthalmologist, with an ortho, a neurologist, and an early developmental therapist, so that we pick up problems because of any sort of reasons like prematurity, jaundice, or convulsions, or anything which could probably be a cause leading to CP. So that's what, as individuals, probably we can do at our capacity. At a larger level, yes, creating awareness about CP. There are still instances when people label CP as polio. Now, polio is eradicated, but still in this modern world where everyone knows about it, still people are not aware. Maybe we in our own bubble feel that everyone knows. But yeah, outside on the grassroots level or other places, it is still, there is this awareness is still lacking. And one of the steps what we have taken today as a webinar to create awareness, I think each one of us can do our small little bit and create awareness. And so I have been working on this currently. Working at a larger scale at the national level or country level would, of course, all the organizations are trying to get in together and work on these things. We have now got in place the hip surveillance program, which is now a national hip surveillance program. So it is helping again with orthopedic problems in children. So I think a small little bit everyone of us is doing, and collectively, if we all come together, a lot more can be done, of course. So, I mean, this was a very nice webinar. And apart from the World Cerebral Palsy Day, we also celebrate the National Cerebral Palsy Day, which we fondly remember the first female orthopedic surgeon, Dr. Mullah Feroz ma'am, who was part of SRCC Children's Hospital, previously known as the Children's Orthopedic Hospital. And myself and Dr. Pradnya, we are very proud of working on the same grounds where she has worked. And I have been lucky to see some of the children which she had treated, and those patients are now following up with me, and they got operated with me. And one of the patient had very fondly sent me a voice note that my first surgery was with a female ortho there, and I used to be really scared of her. And now the last one was with you. Now he's a grown-up individual. So, I mean, it feels nice that somebody was working. She was there, I think, before the independence, 1947. Prior to that, she was working towards polio and then later CP. So we fondly remember her during this month, and we celebrate National CP Day in her honor as well. And we are so much thankful to Heartfulness to create this awareness. And I hope it reaches out to larger masses. I think that's all we all want together. Yeah, thank you, Dr. Snehal, for having us together here.
Thank you. I think this was a wonderful, brilliant webinar in the series, and I look forward to, I invite you both, and you can bring along your friends to come to Kanha Shantivanam. We have a lot of offerings through Heartfulness. We have Family Connect programs, we have Corporate Connect programs, we have physician retreats. So any of your friends wanting a retreat, you are welcome. And the beauty and the serenity of Kanha. And of course, for the movement of cerebral palsy, we'll be most happy to house a wonderful team in Kanha which can support your dreams. Thank you so much. Thanks.
Thank you.